informational hearing on Bill 340-33. Before we go on, I'd like to recognize the presence of my colleagues. To my immediate left, Speaker Pat, thank you very much. Vice Speaker Cruz, we have Senator Tom Atta, Senator Rory Respicio, Senator Tommy Morrison, Senator Tina Rose Munoz-Barnes. Thank you very much for being here. Also want to thank you for all the administrators from the different agencies for being here. It was a late notice. We issued this notice on Friday. That's why it's called an informational hearing, because we're not subject to the 5-day notice requirement. But I thought it was very important for us to be here this evening to discuss and put out to the public Bill 340, at least this option that would provide immediate assistance to our only public hospital. And so I thank you all for being here. I thank our community advocate, Senator, I was going to say Senator Tom Shea, but it's Dr. Tom Shea. Sometime soon, right, Doc? But Dr. Shea, thank you very much for being here. And also those in the, for those from the general public, thank you for being here. I want to recognize former Vice Speaker Ted Nelson as well. Thank you, sir, for being here. So, we're here because the Bill 340 that I introduced with Senator Tony Atta and Senator Rory Respicio was in a committee prior to it being re-referred to mine late Friday. And there was an announcement that it will never see the light of day. And so we thought it was unfortunate because really this plus, of course, the governor's measure is the only other option on the table right now to provide assistance to GMH. What we have in Bill 340 is an authorization for the administration to refinance existing bonds and loans that we have. More specifically, it's to refinance the Section 30 bonds that we have, the Okkodo leaseback bond, and as well as the Bank of Guam loan that GMH currently has with Bank of Guam. And so the intent of this legislation is to take to refinance those and take whatever savings we have to net at least when we introduce this $30 million needed to pay off the vendors of the Guam Memorial Hospital Authority. We know that there's other options on the table from the governor's bill that provides expanded borrowing for other purposes, but I want to make it very clear this evening that this measure before us is to deal just with the vendor payables. Once this gets on the floor, of course, there may be attempts to try to amend it, and I welcome that from any of my colleagues. But my desire is to ensure that the hospitals provided the resources today to pay the vendors, because we know that it's threatening patient care, and maybe we can ask the administrator to speak a little bit about that. Unfortunately, we have to do this. This is something that borrowing is not something that is a choice that I'm sure all of you here, even our fiscal people, will tell you perhaps will not be the best thing to do. However, unless someone walks in here with a checkbook that has $30 million to pay the vendors, it's really the only option. But again, we're going to continue to receive options and alternatives from anybody from the legislature and also from the public. But the most important thing that we're going to focus on tonight is to ensure that the hospital is given this authority, given this resource to be able to pay its vendors. Okay, so we'll have the way we'll do this tonight. We'll have GMH here to explain really what the situation is, how this bill may affect GMH, and then we'll have our public health officials also be able to provide some statements. I want to ask some clarification, because one of the options that's been thrown out there is that we simply redivert Medicaid money and pay the hospital more. Really essentially shortchanging our primary care infrastructure, which is something that I've been working with you folks, something we're trying to strengthen. Because we know we strengthen the primary care infrastructure, then you alleviate the burdens on GMH. And so maybe we can talk a little bit about that later, and also to go on record, because another assertion that was made is that public health picks and chooses who it pays. Public health doesn't pay anybody. You process the claims that are that are received, and it's DOA that makes the payments, right? And so that's why we have our DOA director here as well, to perhaps give us your position on how are these things, how are payments made, and so we can put that issue to rest. Okay, so we'll do that, and we have our the fiscal team represented by Mr. Lester Carlson, who's here. However, because I announced a official public hearing on Bill 340 for Monday next week at 4:30 p.m. We can perhaps reserve some of the comments at that time when we have the official public hearing, or any of the members here wish to ask him questions. He's available here to answer those questions. But I just want to also say that whatever statements you make this evening is being recorded, and we'll ensure it's attached and appended to our committee report for Bill 340 when we do have the official public hearing next week. Okay? So, Mr. Peter John Camacho, am I going to start?
Thank you, Mr. Chairman, members of the committee. Buenas and saludo. My name is Peter John Camacho, Hospital Administrator, CEO of the Guam Memorial Hospital Authority. On behalf of all of our stakeholders, some of who are present here today, undang ko na si Diyos maasi for the opportunity to share information about our island safety net hospital. We are all aware of the challenges and problems faced by the hospital. The hospital has a mandate to provide care to any and all who present to its doors, regardless of their ability to pay. Aside from the group of patients classified as self-pay, the hospital's largest group of insured patients are members of the group more commonly known as the 3Ms, these being Medicare, Medicaid, and the Medically Indigent Program. True self-pay are those with very limited or no means to pay for the services they receive. The 3Ms reimburse the hospital at a set rate. Essentially, for the GMHA with the 3Ms, this translates generally to a significant underpayment for services provided. What happens is that the hospital is short of funds it needs to operate. There is a cost to provide these services, and we are challenged to make up the underpayment reimbursement, and more so for those with no or very limited ability to pay. Despite this glaring issue, the Guam Memorial Hospital Authority team is made up of very dedicated professionals across all areas. During our recent triennial accreditation visit, each member of the survey team continually expressed how impressed they were that throughout the 4 days they were evaluating how we did our work and how well we demonstrated compliance with their stringent standards, not a single one of our staff was shy. Usually during a survey at other organizations, they encounter instances where staff distance themselves from the surveyors. Well, at GMH, they almost felt like a rock star. Even though they'd start their review with one staff, by the end of their visit at that location, they would have an entourage. Staff were unafraid to ask questions, which they saw as a willingness and a desire to learn. The surveyors, because of these observations, encouraged the GMHA to consider joining the Joint Commission on their campaign for healthcare institutions to become high reliability organizations. According to Dr. Mark Chasen, President and CEO of the Joint Commission, high reliability is a concept that comes from the study of industries that have maintained very high levels of safety over long periods of time, like commercial aviation, and what that means is consistent excellence. For healthcare, it means establishing near zero rates of failures for critical quality processes and making sure that they stay at that high level of performance across all services for very long periods of time. While the surveyors were good at highlighting the positive things they encountered, they also showed us that they are aware of the challenges we face during several sessions with leadership and important hospital committees. They asked pointed questions about how we address those challenges in the short term and what we were doing to address them moving forward for the long term. You know of the many unflattering ways that GMH has been described over the many years, including the famous "Get Me to Hawaii." There are numerous articles, official reports, and media editorials that demonstrate GMH's challenges and ills. The hospital has been told how and what the prescriptions are for its recovery, sell or privatize because government can't run services, as well as the private sector enter into partnerships, fund adequately or not, and likely others. Over the years, though, there have been many sincere efforts to assist the Guam Memorial Hospital Authority. The Office of the Public Accountability notes that the hospital is able to continue operating because of the cash infusions it receives from the Government of Guam. However, with its mandate to provide care regardless of the ability to pay, the hospital will continually need to be subsidized. The mandate to care for all is a noble policy. According to Mahatma Gandhi, the true measure of any society can be found in how it treats its most vulnerable members. We here on Guam have it right. Our people deserve to have access to quality medical care, which needs to be reimbursed in order to continue to be able to provide that service. Working together, we can find the best way to continue our mission. Thank you.
Thank you, Mr. Camacho. Anyone else from your team?
Good afternoon, Senators. My name is Larry Lizam. I'm the Medical Director of the Guam Memorial Hospital, and I'd like to just submit some testimony. I know that your bill will be addressing the vendor payables, which certainly is much needed to keep the operations going for the current care that we provide at GMH. And not a day goes by where we struggle with finding resources to provide care for our patients. The list of vendor payables continues to grow. I do want to share, though, that along with the need to pay the current vendor payables, we also recognize that the current level of care on this island has really, taken a step forward. And in that step forward, we have identified centers of excellence that we think that is essential to be part of our hospital mission. And that includes cardiac care, oncology care, and interventional radiology care. So in the going forward support for our only hospital, where patients still choose GMH as their primary place of care, we think we need to look at providing the resources for my doctors at GMH to provide the care that they basically specialize in. I am bringing a board-certified oncologist to be part of the hospital staff. We hope that would address some of the challenges that we have in the outpatient setting. It will provide a continuity of care. We have interventional radiologists that can offer many procedures that can save lives. And unfortunately, we've been before this body with regards to new fees that we've identified for new procedures. We have more procedures that we can offer patients, including stroke that are done through interventional radiology. We also basically talk about the cardiac cath program, and GMH was the first to start the cardiac cath program. We have the institutional support, staff, talent to basically provide that service. We have to provide reliable service for the people of Guam. In my 27 years of practice, I find it, that sometimes, unfortunately, in the private setting, when the private, whether it's clinic or practice physicians take on the responsibility of providing the only support for our people, at any given day, people can walk out. GMH will never walk out from its obligation to take care of the people of Guam. So, we will be there for the people of Guam, and we will continue to support these services that have been now introduced into the island as part of our standard of care. So I'm hoping that this addressing the borrowing to pay vendors would also look into opportunities for more service to save lives, so that we can continue to provide greater service for the people of Guam. Thank you.
Thank you, Dr. Lizama. Dr. Shea?
Thank you, Senator. all the senators here today. And I'm so happy that at least we got to come out and express our views, pros and cons of legislation. I echo Dr. Lezama is that, advances in medical care have gone beyond what our hospital can do for the patients. We can do minimally invasive surgeries, but we don't have the equipment to do so. So I ask the senators here to really consider, from our testimony or from the physician side, that to really consider the capital side. I know that this is a Band-Aid over a bleeding wound, but I think we need to look at the revenue stream as well. And for OBGYN, I know that maternity side, we've taken care of that side, thanks to Speaker Juan Pat and the rest of the legislature who supported it. That's going to move forward, but we also need to look at other areas of the hospital that needs improvement. And Dr. Larry Ozama mentioned cardiac care. Absolutely, we need cardiac care. People die from heart attacks all the time. We need interventional radiologists. We need all these people that have to come on board to Guam Memorial Hospital. But if we don't provide a facility for them to practice, then we're not going to be able to recruit them. And I met up with several doctors this past weekend and some specialists who want to come to Guam Memorial. And before Dr. Noel Concepcion left Island, he wants to come back. And he would like to practice open heart surgery at Guam Memorial Hospital. He's done 88 open heart surgeries at Guam Memorial Hospital over the last 10 years or so. He would like to come back to do so. So I'm hoping that you can look at the capital improvement side. I know that, Senator, you said you want to talk about the $30 million. We'll talk about that, but just let us express to you that I think one of you, or all of you, should consider amending your bill, because certainly San Nicolas is not going to let his bill, governor's bill, out. So I'd like you to look at the provision for the capital improvement side of the governor's bill, and however you fund it, because we're going to need that. If not, we'll come back to you again for another $30 million. Now, going back to the $30 million, I'd like to suggest an amendment. Instead of the $30 million, why not give us $50 million? Because by the time we get the $30 million, we're going to be $10 million short. So rather than coming back to you again for the 5th time or 6th time, no matter how many times, increase the $30 million to $50 million. However it may be, so that we have some cushion. Because we know the vendors are going to continue to give us supplies, but we don't have the revenue generator, like Peter John said, that patient comes in, they don't have money to pay their bills. We can't go after them. We can send them to collection agencies, but if they don't have money to pay their bills, they don't have money to pay their bills. If they have $10, they'd rather spend their money on bread for their kids, and they're going to do that. Doctor's bills are always the last to be paid, and that's a fact. And hospital bill is behind doctor's bills, probably. But we can send them to collections, but ain't going to collect anything. So with that being said, I think I'm going to keep it and cut right to the chase. I think $30 million is not enough. I'd like you to consider increasing that amount to a minimum of $50 million. Okay, give us some cushion. Give us some cushion. Now, as far as the amendment to the capital improvement, I'd like you to consider that as well. Give us the amount so that we can make capital improvements so we can sustain the revenue source for Guam Memorial Hospital. If you don't do that, again, we're going to come back to you. Don't make the same mistake. You don't want to make the same mistake. So make the capital improvement investment into Guam Memorial Hospital. I made my investment here. GMH does not pay me a dime. I'm not part of that GMH financial team. I'm independent, and I'm here to speak to you on my own accord for my own patients and also for all the patients that I see throughout Guam Memorial Hospital. Just last month, I was at GMH for appendicitis, and I was in the same emergency room alongside any other patients. I didn't receive special treatment, okay? But when I left, I paid my bill, because that was my obligation. But not everybody is able to do that. And I see that to the patient who's laying next to me. They're crying. They don't have the money. But we take care of them. Our doctors and nurses take care of them. Okay? Those are the things that you don't see every day. But as doctors, we do. We see that every single day. So I asked you, I know you may not like amending the bill to include capital improvements, but I'd like you to really consider doing that and increase the $30 million to $50 million. Give us some cushion. Thank you. Oh, one more thing. I got to bring this up because Senator San Nicolas brought the issue about his solution was increased payments to Medicaid for the hospital. I honored that request. I said, you can have all my Medicaid patients. You can have all. I stopped taking Medicaid, period. I talked to some of my colleagues, and we'd be very happy to honor Senator San Nicolas' request and stop taking Medicaid and MIP. Now, if you think that's a solution, then so be it. It's not the solution. I can tell you that right now. But Medicaid is not the issue at Guam Memorial Hospital. Certainly, I think increased matching Medicaid fund, like you suggested, for MIP is going to help. But everybody needs health care. But Medicaid for the hospital, if you increase it, sure. But I think the community providers now, many of them do not accept Medicaid or MIP already. And that will tell you something. But, in honor of Senator San Nicolas, I'd be more than happy to say, hey, I will not take any money from Medicaid. I won't accept any Medicaid. Give all that money to the hospital. Thank you.
Thank you very much, Dr. Shea. And first of all, I apologize if you took that comment from another senator, and now our people are going to suffer. The primary care infrastructure that I talk about, because I say that I share your vision. That is not the solution. And we'll have public health here explain that in a little bit. That we want to be able to support our primary care so that it alleviates the burden on GMH. And so, I will work with you, and I hope you reconsider that, because we need good primary care doctors like you to be able to continue seeing our medicated MIP patients. So,
I think, Senator, accepting Medicaid is not for private practice. It's not a way to pay our bills, because we have an overhead that we have to pay.
Right.
We pay our taxes. We don't have a tax waiver. We have to pay our staff. We've got to pay our supplies. A Medicaid for many of us is a charity care that we provide for the Government of Guam. We don't get paid 6 months to a year, and the reimbursement for Medicaid is very, very low. So in reality, we're actually doing a favor for Government of Guam to accept those programs. But I don't think your colleague in particular understand that process. So I think if he thinks that Medicaid is the solution, I can tell you that it's not the solution. And we're trying to get more people to accept Medicaid MIP. But like you said, I think you don't have to apologize. You didn't say it. He did. But I think certainly, going back to your issue here, I'll cut to the chase. $30 million is not enough. Give us $50 million and add the capital improvement onto this so that we can sustain the revenue source.
Great. Thank you, Dr. Shea. And just before we move on, I want to talk a little bit about this, because 4 years ago, about 4 years ago, when we authorized the refinancing and to expand the initial $25 million that was authorized, and to take advantage of the full $25 million, the Bank of Guam loan. At that time, the hospital administrators, previous to both of you, were here, and I said, the first thing I said is that, how are you going to assure me that we're not going to come back into this cycle again? And so they had a plan. Part of the plan was instituting changes in your pharmacy department, in getting it online, and all of these have barcodes, and using technology to really be able to control the pharmaceutical, the supplies that you have. And so, and we know what happened then. That administration is gone. It's a different administration. And so that's where I'm kind of very, it's hard for me to be able to say, okay, we're going to give a little more, because, of course, the desire is not to come back to this, not to be able to come back. And I know the governor's plan is to, bring in more services that would generate more revenue, and that's how we will be able to cover these shortfalls, right? But I just want to hear from the administration, from the GMH administration, is what initiatives are in place now to kind of hold the line in controlling, in us to come back into this situation, and really explain, make the case on why we need to be able to give that cushion. Because I understand initially, there was on the governor's plan, there's that $30 million for vendors, an additional, I think, $10 million as a cushion, right? But what's it going to take aside from we're going to rebuild a wing in the hospital and provide new services? What is the hospital doing to institute changes to help control the line on our supplies? Because we've known from past audit reports that some of the supplies are there and are probably more ordered, and then eventually they're expired or not used. What are we doing about that?
Mr. Chair, before you do, I'd just like to make sure everyone acknowledges that Senator San Nicolas is here, and he is in the audience behind you.
I'm going to start with, certainly, Senator, we've looked at revenue enhancement for the hospital. And, there is an opportunity for us to, with Centers of Excellence, to look at the way we transform GMH from a long-term stay hospital to short-term, acute care model. So the idea behind this Centers of Excellence is to have chemo infusion infusion therapy and blood transfusion therapy in an outpatient setting, so that we can get better reimbursed from the 3M population. So we have looked at revenue enhancement opportunities. These services these Centers of Excellence is a way of creating and capturing more revenue for the hospital. That's one of the initiatives that we're looking at. We're starting that already. We're already investing in hospitalists that will address basically short-term stay and efficiency in care.
How about your pharmaceutical tracking system? I know that was an issue that was brought up even in an audit. I know the public auditors here. Thank you for coming. There was an audit done a few years ago about the tracking of pharmaceuticals, right? And that was previous to your administration, to your GMH administration. It was the people before you. But what has changed? Has the issues that were brought up in that audit been addressed?
Sir, we continue to.
Ma'am, you can come up. You can come up if you want to add to that. Go ahead, Peter John. I'm sorry.
No problem. In looking at those findings that you were referring to, I know that the pharmacy department is taking a look at how they can better track those expenditures, the way the products move back and forth from the supply to the patient, and then restocking and all of those details. One of the things that we would like to have implemented is an automated medication dispensing system that would further control that, so that we can make sure that we give the medication to the patient, so that we can then appropriately charge for that and prevent wastage, cut down on losses. So that's one option that we are considering. As far as other kinds of costs, we're looking at cooperatives, buying cooperatives, purchasing cooperatives with companies. We're looking at, can we go direct to the manufacturer so that we can get a better price? Trying to cut out some of that additional expense so that we can realize savings on the monies that we spend for pharmaceuticals and supplies.
None of those have actually been instituted yet. None of these those corrective measures have been instituted. So, I'll give you time, PJ, between now and Monday, when we have the public hearing on the bill, to perhaps you can get more information on it and be able to explain further on what initiatives have been taken and what are the initiatives moving forward. But Benita, you want to add?
Yes, Senator, I just wanted to point out that $5 million for the dispensing system for the pharmacy is in that 170, part of the 170 million. And until we get that, there's always going to be, that audit finding that, it'd be difficult it'd be easier to track the individual medications.
Okay. Vice Speaker.
The most recent audit of the hospital evidenced that in 2014, there was $5.8 million that was never billed, unbilled receivables. The two good doctors keep talking about centers of excellence and getting new revenue-generating things. 2 years ago, it was 5.8. This last fiscal year, how much was unbilled, Benita?
Well, thank you,
In the audit, how much was unbilled?
Well, let me explain.
Answer the question, how much was unbilled?
But I need to explain.
Just get the number out first.
Okay. There was about 14 million that was unbilled at the time, but there is a timing difference. The unbilled now is 2 million.
For this fiscal year, or did you collect the 14 from that year?
We've billed that, Senator. There was, if you will recall, there was a system conversion at the beginning of the fiscal year, and we were not able to bill. But for your information, if you go through the audit, we billed $15 million more last year than the year before, and we collected $5 million more than the year before.
But it also said that you had unbilled 14 million. Is that
You
correct?
need to understand the makeup of the hospital. There's always going to be some unbilled because there's about $6 million worth of patients, charges that the
But
patients...
those unbilled...
That
Anita,
includes the patients that are
but
still in the
those
hospital
were
that have
unbilled
not
because
left the hospital.
You had problems with the conversion. Is that correct?
We have corrected. We have made tremendous
It was
improvement.
unbilled, and that's what was in the audit. Do I need to get the auditor to talk about it?
Senator,
Yeah.
I have the audit here.
Then read it.
Yes.
No, read the
No,
section into the record.
Yeah, but that's one period in time. But I'm telling you now that there have been tremendous improvements since FY14.
And what
FY15,
were...
we built
what the
$15 million
chairman then is asking,
more.
what have you done to make sure that in the next fiscal year's audit, unbilled is zero?
It can never be zero. That's what I'm trying to explain to you. It will never be zero because there's patients in the hospital that are still there. We don't bill that. So the report is going to show unbilled because there's always been, it's like construction in progress. That's a billing in progress. So you don't bill that. It's going to reflect unbilled.
And how many millions is that? Is that going to be 14?
No. Right now, it's about, I'd say about 4 million, but the unbilled right now that are ready to be billed out is about 2 million.
Okay. There was a discussion also about the Center of Excellence doing all of this heart stuff and the fact that Dr. Noel Concepcion did about 88 open heart surgeries at the hospital. I know neither one of you were there. I know Peter John was doing some of them. If I was to make a FOIA today to send to the hospital, and I was to ask if all of Dr. Noel Concepcion's open heart surgeries were billed and how much were collected, what would that report state?
I don't have that information for you, sir, but I'll get it for you.
And were you aware that his last set had not been billed as of last year?
Yes.
Okay, then I'll FOIA it, just so that you and Dr. Shea understands. Part of the problem is not just the revenue being generated, but an attempt to collect.
Yes, sir.
Where are we with the hiring of a certified biller?
Senator, we are training our billers right now. And we have built, like I said, we built $15 million more last year. We hit $159 million.
But
the year
thing
before,
is
it was
that
143.
the need for a certified biller and your new board member was the one that told me, I didn't know about certified billers.
Okay.
It was your new board member about 5 years ago that told me about the fact that there was a need to have a certified biller. So that when you send public health and social services $20 million of billables for the 3 M's, that it is as close to the 20 million that they can possibly get to reimburse you. But because your billables, you don't have a certified biller, it doesn't comply with theirs, and so consequently they're only giving you half of what you ask for.
I beg to differ, Senator. When we bill the 3 M's, we only get about half of what we bill because of the contractual adjustment. You don't get everything. You'll never get everything.
Who is responsible for the contractual adjustment?
That's just how we're paid. If you bill $10,000 for someone that stays in the hospital, for example, 3 days, and they put a pacemaker, the pacemaker costs $5,000, and the total bill is 10, we only get 3,000. Contractual adjustment is the 7.
Who makes that contract? Who signed that contract?
It's understanding how the hospital, the payer makes, how the hospital is being reimbursed by the 3 M's. we get paid per diem for inpatient stay, and then we get paid a percentage for outpatient services. And that's why we're trying to change the mindset and try to shift to the outpatient setting, because we get about 80% of the services paid.
How many trips did you make last year to Washington, D.C. to work on the readjustment of the...
I made several, and we were successful in getting some adjustment money for 2007 and 8. That was 3.8 million.
But how much, were you able to get the TEFRA rate increase?
We are working on that, Senator. This is a long process.
I understand, but
If
the
you
thing is-
understand TEFRA, they rarely give it, but they will give an adjustment. There's 3 ways of getting reimbursed from
Yes, I
Medicare,
remember,
right?
Benita, because it was one of your first hearings here that you did not know what the TEFRA was. And I had to point it out to you.
I beg to differ.
Yes, because you were sitting right there when I called you out on it. And the
Okay.
thing that needs to be clear to the public is that the TEFRA rate is not set by this legislature.
I knew that.
No, I know.
I didn't say
but
that
the-
you
but-
said it.
But the thing is that the public keeps getting its legislative action is what's affecting TEFRA. But that's federal, U.S. Congress. We can't set that. Please make it clear. And Peter John, would you please address the TEFRA as not being a local Guam legislature problem, but something that your predecessor and her have been trying to get addressed, because like Promesa, where because of helping Puerto Rico, we're now under credit watch, in TEFRA, only the 4 territories were included in there, plus the sanatoriums in the states.
Senator, for your information, we had the heart project. They approved the rebasing for that. So as a result of that, we got about $500,000.
I understand.
So we continue to pursue.
But the numbers, we keep hearing that it's because we haven't been able to increase the rates up. It's not us that set the rates. And this is an informational hearing, and I'm trying to inform the public that it is not the Guam legislature that's holding you back.
But what about MIP? Wasn't it?
And then
that's
on
what I was
that one, who? I found something. In 1977, I wrote the executive order that created the Guam Health Planning Council, and unfortunately, it's been abolished.
Hopefully we can bring it back with
Yes,
165.
But I'm trying to figure out who has the current responsibility of resetting the rates for MIP and for Medicare.
Not Medicare.
No, I mean MIP
We
and
have to change the
Medicaid.
law.
Who currently has the responsibility?
Yes, and so please speak into the mic, and that's a good segue in, because the Vice Speaker's right. We talked about this during the OPA's hearing. TEFRA is a federal. It's federal. However, because Guam, it's in law that we mirror Medicare rates. That's why our MIP and Medicaid follow that. We can easily change it, but we have to make sure we have the additional funding to back it up. So please, can you explain that so we can get it very
Senator,
clear?
can I interject real quick? Since before we go on to that subject on the billables, I'm not surprised with billables still in the millions, because in private practice, if you ask me how much money do I have that's unbilled for services, I can tell you that I have tons of, because part of the hospital, before they can send a bill to the insurance companies, you have to have several things. You have to make sure your dictations are done. You got to make sure your records are straight. You got to make sure that all these logistics are done before you can send the bill. Sometimes that takes 40 days, sometimes 45 days, or sometimes 60 days, and sometimes that takes 6 months to get it done. And if the patient is in the hospital for 40 days, you can't send the patient, bill the patient until the patient goes home. In private practice, and we do our best in sending the bills to insurance companies because we want to get paid within your 45-day law. By the way, that law is not working very well. Okay? Because we get paid beyond the 45 days, and we don't get any interest payment for that. There's a loophole that the insurance are getting away with. But be it as it may, Vice Speaker Cruz, I think you asked a very good question. And if I may explain the reimbursement part in sending the bills out, even our particular clinic, we don't send the bills out immediately. We try our best to do so, but it's difficult to send it out without your records. And part of it is the doctor's fault, I gotta admit. We have to take time to do our medical records. And I'm just as bad as any other doctors there. But with the new system that's kicked in, the CPOE system, you know, we may not like it because it's not on a Mac computer, because I use Mac, so I have to get used to the PC. But I'm getting used to that system. My records over the last 2 weeks had gone down to 0. All my dictations are in there now. My operative report are in there. So I think you're going to see a system improvement with collections and billings. I hope that they do, because the records are there. So it's being completed in a timely manner. So I think part of it is all of our fault, and the doctors included, that we need to finish our records. And I just wanted to make sure that you understand that even the billings from my particular office, we don't get it out. If I bill $100, if I have $100 to bill, we probably still have about $20, maybe $30 that's unbilled as of today. Yeah.
But you don't have $14 million in one fiscal year that was never billed, which
Well,
is different from $140 million that was billed and only 80 was collected and 60.
Right, but how
was-
much of the total bill is supposed to be in a year at GMH?
They said 159.
So 159 and 14 million is what percentage of that? 10%. That's pretty darn good. Because in my office, I have 20% probably that I haven't sent it out.
And we're trying to figure out how we can get more efficient.
Yes,
So
and I
that-
explained that to you. I think it will get more efficient because of the CPOE system, that I'm getting my dictations into the system as the patient goes out of the hospital. Because before the system was in place, what happens is that we have to get call from the medical records and we go in and do the dictation. Sometimes we're very late because we're tired. We have to take care of patients first. So when I get home, the last thing I want to do is paperwork. Don't give me more paperwork. I will tell Larry, take that away from me. I don't want to do any more paperwork. But now with the system, I'm able to log in from my home remotely to the hospital, and I'm able to enter my operative report. So once the operation that I've done and the operative report is in there, the hospital is now able to, okay, this is complete. Let's send it to the insurance. Because if you build an insurance company without the operative report, they'll reject it. They'll say, hey, I want to see the operative report. And that comes back, and then you wait another 60 days. So part of it is the doctor's fault, but I think the system is getting better. It is getting better. I just wanted to
Right.
But 10% not billed is not bad. Not bad at all.
Thank you. Thank you, Doctor.
Senator, but may I
Sure.
clarify Senator Cruz on that, because he keeps going back to that unbilled. That was timing. That number was, that amount was billed subsequently. So I have the management report right now. The unbilled, not final bill yet. It's 2.8.
And even
Yes.
if it was billed and it was like 7 months late, will the insurance company honor it?
If you remember again, there was that system conversion. We notified the insurance companies that GMH had challenges in the conversion. So they allowed us, one company allowed us to bill up to September, and the other one August, and then the other one said to go ahead and submit by December last year.
And so how much are they willing to recognize of that 14?
They recognize the billing, what we submit.
Well, are they
as-
going to recognize and pay all 14?
The 14 is comprised of a few, they're not all insurance companies, because some are 55%, I would say.
Of the ones that you sent to the insurance companies,
Medicare,
how much of it is going to be paid by the insurance company?
we have been paid.
And how much was that?
I can't give you the total amount right now, but about 43% of our collection are from the insurance companies.
And if memory serves me right, the governor announced when he took over the hospital that he issued an edict that 75% of the bills that were sent to the insurance company was to be paid within X number of days, and that you would then quibble about whether or not you get the other 25% or anything at all, or if there's how is that working?
Well, Senator, we have been meeting with the insurance companies, and we finally had 4 contracts signed. I know you've been harping about that. And in that contract, we removed the 8% discount. And, you know, the insurance companies have been doing a lot better I say 75% of them are remitting payments on a timelier basis.
Can I add one more thing about how much you bill and how much you collect, if I could, Vice Speaker? Judging from my 20 years of practice in medicine, and I think Larry can attest to this too, if we bill, let's say I send an insurance company a bill for $100, do you expect me to get the $100 back from the insurance company? I'm asking you the question.
I'm hoping that you would, otherwise you wouldn't bill it.
Of course I would, but that's not the business of healthcare. Let me tell you why. We send in the bill, for example, the level of visit. It's coded by a certain level of visit. If I code it at level 5, the insurance company looks at the bill and they say, we're going to give you level 3. So instead of $100, I get $60. And that happens all the time.
Okay,
so we go back and we argue. So it's never in one instance where you bill $100, you get $100.
This is informational, so maybe I can get
Yeah.
Public Health and Social Services to explain
Oh,
to us.
yeah. Good. You should do that because when I bill Medicaid $100, I get $40.
All right, so let's hear from Public Health and Social Services how they handle and why when they get a $20 million billable from the hospital that they approve 8.
So,
Well, whatever, 40%.
So, Jim, there's 2 things before that. So, first thing is to please make the clarification that the TEFRA is federal. We know that, but we Medicaid, MIP pay the same way because we haven't changed it. And if we change it, we have to ensure we have the appropriate funding in place. So, if you can explain that, and then go back to what was just asked.
Yeah, and you can. The MIP program, you can change the statute and say pay 100% of what's billed. I don't know of anybody in the industry that pays 100% of what's billed. Insurance companies negotiate a rate. We don't negotiate a rate. We pay what the federal government tells us to pay. The per diem for the hospital is set by the feds, and that's $1,108. But that's, again, you know, this is the most, and I'm sure Mrs. Brooks knows, this is probably the most complicated industry in the world in terms of the paper chase, the amount of records that have to be kept, the requirements for physicians to have to stay involved in the care when they're very, very busy, taking care of their patients in their clinics and then paying attention to the patients in the hospital, and then all of the detail that's in the bills. Most insurance companies could take advantage of the significant error rates that are in hospital bills because of that paper chase. You've got so many people touching a patient and then entering information and billing for the service. I also had an experience at the hospital, which was a very positive one. But again, when I left, I only got an estimated bill because everything wasn't in. And this was just an outpatient stay, an outpatient surgery. But still, at that time, there were still items coming in, so that the final bill was a little bit higher than what was actually. So if you looked at what they had the day I left, that would not be the correct amount. So there's always a timing problems, and Dr. Shea is right. Sometimes you don't get paid until 6 months later. Once you submit a bill, and as he says, if it's at a level that the payer doesn't agree with, you're billing according to a CPT and a diagnosis. And if we look at the bill and it says, well, wait a minute, this service doesn't match that diagnosis, we're going to kick it back and say, can you please give us some more information? And then it keeps bouncing back and forth. And then when you get a third party involved, in the case of where somebody might have been involved in a vehicular accident or somebody may have dual coverage, it delays the payment even more. So there are a lot of people waiting to get paid. Bills get stale. And that's why, one, the need for certified billers is an absolute necessity. If you've got consistently got the wrong CPTs and ICD-9s, you're going to have that problem. But in MIP, you could solve that problem. You want us to pay 100%, just change the law. But that means that $16 million, $16.2 million, will go very fast. Okay, and again, because of the limits that the feds give us, even with the Affordable Care Act, they gave us $268 million and said, that's extra for you. But by the way, you have to find 45% more. So And that's been the challenge for us. And we've been doing some really good stuff with moving a certain band of services out of the MIP charges into the Affordable Care Act, or into Medicaid, because the feds have allowed us to do that for our FAS resident migrants, that we've been able to use that savings that we shifted over to, to increase our ACA participation. So we're at now $153 million left in that amount of money, and it's available until the end of 2019. Okay, but again, the question here is, there's never enough, okay, and there probably never will be enough. So it doesn't matter whether we get the feds to agree to allow us to pay 50%. It's still going to have to, depend on us matching up whatever it is that they're going to allow for. And I think there was that opportunity. I don't know how it, why Congress wasn't entertaining this with the bill that they finally did addressing the debt in Puerto Rico, which really hurt us. But part of that initial attempt was to just have an open-ended Medicaid arrangement where we're basically either 100% or at least at 80-20 in most states. I mean, Mississippi, my colleague from Mississippi who runs that program, they are at 80-20, and their per capita income is higher than ours.
But we've always known, and I have been in government long enough, even with Doris, the issue is with Puerto Rico. If it's given to us, it's going to have to be given to Puerto Rico. And so because they don't want to give it to Puerto Rico, they won't give it to us. So I mean, but that has to be clear out there, because they keep looking, everybody out there figures it's the legislature. And I'm tired of them blaming us when it's not, except for the MIP one. It's not us. And then even in the MIP, you guys still owe me what? Dinner in Paris, in several other places, because the MIP has never been.
No, I thought it was Medicaid.
No, it was the
We
MIP.
were going to run out of money, and we said we wouldn't.
But what about the Medicaid? Are we able to change the state plan
Medicaid,
to change how it's reimbursed?
Well, we can change certain things, but the reimbursement, no. That's a negotiation. I mean, there's some interesting things we could try to do, and I understand that the speaker was talking to Tess today about either going to private insurance, doing those kind of things. I mean, we did something with our foster care children, purchasing Government of Guam insurance for our foster care kids, but that's a separate appropriation. But we also found that we're paying more than the actual cost
than when they were on the public programs.
But that's okay. It was an attempt to see, what you could do with a population like that. We could ask the feds to, and that's the problem, we're asking. It's a state-run program, but we still have to ask them, what we can do. We want to amend the state plan to do this. There's only one state that I know of that's actually purchasing or thought about purchasing insurance for employees whose employer has a health plan, but the employee cannot afford the employee share, and that they actually Medicaid is paying for that employee share. So that shifts the risk over to that other insurance company, and it's generally cheaper because you're paying a monthly premium. That's another thing we can be looking at, but all of that requires state plan amendment, and CMS is willing to listen, but they're awfully slow to act. I mean, it took them how many years since the Medicaid and Medicare laws were enacted to realize that paying for units of care is not going to have any impact on costs. As a matter of fact, it just generally lets the cost continue to rise. Because if you continue to lower your reimbursement to a provider's going to say, okay, I used to do 3 of these and get X. In order to get X, now I have to do 4, so I'll do 4. So you don't, when you reduce the cost per unit, you don't really save. So now at least they're starting to look at things like accountable care organizations, where they're actually linking the visit to outcomes. Okay, Okay, that wasn't done before. It was a lot of it where they were measuring process. How many times did you come in? How many times? But didn't look at whether your blood sugar levels were lower, or whether your cardiovascular system was better because of the interventions. They're beginning to pay attention, because they're spending $3 trillion a year on health care. And the health status of the people in the United States is about 17th among developed countries. So we know that just spending on health care is not the solution. So we can do that. We can talk to them about ways to save the dollars that we have. But there are other solutions that have to be taken into account. We talked this morning about non-communicable disease and behavior change, and how long it's going to take to get people involved in that. I mean, the cost of care for dialysis, I was just showing a director of DOA that, for a 3-month period, one dialysis provider billed us $3 million. And it's a good thing that we have Medicare, because a lot of that gets shifted to Medicare. So it's really, it's a very complicated system. Controlling cost always seems to, we never seem to really get it thought through all the way, because we see all of these unintentional negative kinds of things where we've actually, by trying to control it, we actually increase it. I think that, for your information, Senator, your bill that seeks to refinance the bond and come up with $30 million is a good start. But I think that we really do have to look at a longer-term solution, and that's going to take more than $30 million. That'll take care of the immediate problem, but it's not going to solve the hospital problem. They, over time, and I've lived here for 46 years, they've given away certain revenue centers for whatever reason, okay, that they probably should have kept. And I think bringing some of those things back into the hospital, I think we look at their outpatient procedures, we pay them 97% of their charge. Okay, but it's a relatively small amount. The hospital per diem, the inpatient per diem, is what's hurting them. And they have the incentive there with the per diem, and as Dr. Lizama has said, they try to push short-term stays. Then they're trying to get out of the skilled nursing business and all these other longer-term stays. But sometimes, because a physician gets busy, forgets to discharge a patient on a Friday who should have been discharged on a Friday, and the patient stays there on Saturday and Sunday, we don't pay for those medically unnecessary days. So they lose even that amount, $2,216. Okay, so those little things, and they're small, but they're examples of what happens sometimes, where there's revenue that just gets foregone because they can't collect it.
Mr. Chairman, if I may.
Vice Speaker, did you have something else?
Just one, the 30 million, is it 30? I thought we paid 10 million to get rid of the withholding.
Yes, it's 20 now.
20, thank you.
Okay.
So, Mr. Chairman and Mr. Gilliam, I appreciate, of course, your discussion, because I totally agree that we can't put a Band-Aid on a bleeding wound by just going out there and borrowing 30, 50 million, whatever it is. We're just going to end up back where we, are right now. And we need to really look at a long-term resolution. And although whether CMS, is willing to, I think we just need to continue to have this conversation with them, because there are many solutions. And you're right, and I really believe that the solution is in your department, with the 3 M's. And there's got to be a long-term solution to this. And you're right, I called, Ms. Archangel to speak with her about this to get more information, because we've been having this conversation, and we've been having this conversation throughout the region, because like this expert had told me, is that if you don't fully fund the hospital 100%, and you don't mandate that they have a physical exam, so we want to catch them at the prevention stage, then we're going to be right back where we've started. And so the solution is to insure everyone. And what monies then basically do we have from MIP, Medicaid, CHIPS, foster children, And even, get this, these health insurance companies who are getting QCs, that maybe another thinking outside the box should consider buying insurance for a portion, a number of MIP patients. And even the QCs that are given to GRMC, that they too should then buy insurance for these uninsured individuals. There's a long list of solutions to this, but we need to start now. We should have been talking about this long time ago and not just talk about it. There's a law that's in existence. Right now it's in the books that basically says that the administrator or the director of public health, unfortunately, says may go out and get insurance, to consider getting insurance if it's not more expensive. Now, Tess, you tell me that it costs more for several reasons, the administrative cost. But at the same time, have you factored in the administrative cost as well at public health, that it may be equivalent to what it is that others are doing in terms of utilities, facilities, employees, and all that? You know, I don't have all the answers, and that's why I called you to try to get, some answers. And that's why I've asked the chairperson and even the vice speaker to have a health summit, to have a conversation exactly about this, and to bring in the leaders from Micronesia as well. Because we may take care of everyone here, but if we don't take care of those who are coming in every day, then we're going to be right back where we started. So, we have to look at the bigger problem, and we can't just put a Band-Aid over that bleeding wound.
I agree with that. The issue regarding coverage. Hawaii, where I'm from, we almost have 100% insured. There's really nobody that's falling through the net. And part of that reason is because we have Quest. Quest is the local version in Hawaii of MIP here. But it's not just Quest. It used to be Quest, but now there's HMSA Quest, Aloha Care Quest. There's even Kaiser Quest. And the idea behind that is the private insurances are now accepting the, quote, MIP Quest patient into their program. But the incentive there is that they get paid. But you have to pay the insurance company the premiums to cover the MIP patient. So you need to look at that. And the summit is good because it brings in the discussion. But, as far as the bigger picture, you have to look at your deductibles. Because at GMH, if a patient has a $3,000 deductible and they don't have the money, they may have select care, they may have take care, they may have stay well insurance. But if their deductible is $3,000 and they come in and they only pay $500 of that deductible, they never met that deductible, then they are considered uninsured until that deductible is met, because they will not cover until you meet that particular deductible. So that's a big gap. You have underinsured patients, and then you have your uninsured patients. So when we talk about those who have QCs, like a new hospital, don't just make them take MIP and Medicaid. They would love to take those patients, I swear. Make them take the uninsured patients, because those are the unreimbursable patients. So there's a bigger picture. Right? You're talking about 3 M's. I'm looking beyond just the 3 M's. I'm looking at even the insured patients can't meet their portion of the deductibles. And if they don't meet the deductibles, they're uninsured. That's why healthcare business is very complex. Very complex. It's not your ordinary business. And there's more variables to it. Yeah.
And if I may just finish this with my conversation with Tess, and she had a very good point, is that the other would be the premium that's being charged. So like take just the foster children, that it's far more costly in terms of their needs and I was going to ask the chairman too, is that she actually handles those programs, and yet she's not even part of the negotiation team, who maybe could go in there and really negotiate, of course, a health premium for those 3 M's. And so that is definitely something that, we should really consider. I like the idea that this is an informational meeting, because I want to get as much information as we can so we can really solve this once and for all. I mean, I know, like you said, Benita, we're never going to have zero. I understand that. But we can definitely, if we can get 80% of what insurance companies normally would be paying their share, then we're only going to be chasing after 20% versus right now 100%. And to me, I'd rather be chasing 20%. But that can only happen if we start to insure, everyone. So I'm here to get more information. You see, from you, I want to learn, and I want to share a lot of information as well that everybody else is talking throughout the region. But they can't do it alone, and we surely can't either.
Yes.
Thank you very much to our Madam Speaker, and I'm very happy that she shares a lot of of what we put forward. We actually have a bill on in this session that actually includes her and includes not her. I'm thinking of you right away, but Public Health and GMH to be members of the negotiating team. However, we got major pushback from that. That's why we never, moved it through. Also, I want to just invite everyone again to take a look at this task force report that we put together for GMH. It doesn't just deal with just GMH. It deals with the whole system of care. It talks about the word that we don't use here, the word, but it really is. It's universal health care. We have to have some form of that here to be able to ensure as much of our people as possible. I want to credit the speaker also for Public Law 33-143. I call it the I Love You law, which directed Gita to publish a request for information for the hospital. But I credit her because part of the items there that we're asking for information deals with a study on getting a regional health insurance in place, a study on perhaps privatizing MIP and Medicaid. And these are all, things are moving. And so we just got to be able to support it and see how it's going to come up. I mean, that law was dubbed as a law that is going to sell and privatize fully the hospital to a predetermined entity, which we all know that's not the case. So things are moving, and that's why when we talk about this $30 million that's needed for GMH, we need to be able to look at that, because we know that there's solutions, whether it be the plan that we've put forward in the task force report or the governor's plan. Those are things that have to be put on the table. We got to discuss it. We got to get the public's input on it. So I just want to thank the speaker on that. I know you want to continue your, yes.
I just have a question, because we keep on saying we have to increase the reimbursement of Medicaid and MRP. With Medicaid, we pay Guam Memorial Hospital per diem rate of $1,108. It used to be $332 when I started way back. And for outpatient, it used to be 32%. It's now at 97%. They were able to increase it. So it's up to them. It's based on the cost report. But my question is, if we do increase the reimbursement of Medicaid and MIP, do we have the money to support it? Can we match the Medicaid program? The Medicaid program right now, the ACA funding is already $153 million. So that's up to fiscal year 2019. If there is an extra, maybe they will roll it over or may not. So if we run out of the ACA, where are we going to get the money to pay this Medicaid if you increase the fee? I think the solution is, if I may suggest, is to reduce the inpatient admission at Guam Memorial Hospital. How can we do that? Private providers, primary care, reduce the inpatient admission. The hospital can create their own hospital-based outpatient clinic, which they can bill at 97%. But it's a lot higher than the clinic outside. So that means that since most of our patients goes to GMH, why don't they create a hospital-based outpatient clinic? At least they can monitor the patient, they do the primary care, they admit if they need to admit them. Because currently, most of the physicians, I would say, because if they don't get paid timely, they close. What do our patients do? What do? They wait until they're so sick, they're very sick. So what will happen? They get admitted at the hospital. So they.
Yeah. And
See,
so
that's one issue that we have to resolve. We don't have control over the payment of the OA.
Can you say that again? So who pays Medicaid? It's not public health, because there was that out in the public that perhaps you are shortchanging GMH because you're paying private providers, but public health does not pay anything.
No, we just process claims.
And
We
how do you
don't
process
control
claims? Do you process claims? Do you put GMH claims aside and process the others first? How
It's
do you
the
do
same.
it?
It's here. The unprocessed claims are all June and July. We're up to date on processing claims. And there are some claims that's lagged because of some documentation, like what Dr. Shea, I'm not sure, or Dr. Lisama saying. They bill us 99285 or for ER or 99215. It depends on the level of care. There are criteria. Our workers are certified, so based on your documentation, because we only base it on documentation that you provided to us, if it's level 1 or level 5. Based on your documentation, you're only level 3. We're only going to pay you level 3. That's why documentation is very important, because we don't have basis. We're not in the clinic to see how you treat your patient, how you assess your patient. It's based on history, physical examination, and medical decision making. We study this. The certified billers study this on how to audit those claims, and we do teach our staff how to do that. So documentation is very important.
Thank you. I wanted to make sure we got that on record.
Senator,
So with the, yes.
can I just add to that? You know, and again, we've been talking about increasing funding for Medicaid and MIP to help the hospital. I agree with Ted. This is not about increasing MIP and Medicaid funding. This is really about providing efficiency and delivering, efficiency in care. When we talk about the outpatient services, centers of excellence, we're talking about capturing them in the outpatient setting. And again, I want to be clear to the public, since this is informational. It's not like you're going to be there for the 3 hours. You have a 2 midnight, opportunity to be classified as an outpatient. So in the hospital setting, you can stay up to 2 days and still be paid on an outpatient setting. So yeah, our plan going forward is to try to capture patients in the outpatient setting by, again, delivering efficient care. When somebody comes in for blood transfusion, they'll be ready to get their blood transfusion, be out in the next 24 hours, and be able to send home. Now, staying in the hospital longer for 3 days translates to $3,000. Okay, giving transfusion in 1 day and sending the patient out in 1 day may give you $3,000, and it breaks even. It's just that you've delivered more efficient care. So part of the sustainability plan and our mission here is, yes, we're going to set up an outpatient service. We really feel the struggles of patients that are coming in and out of the hospital. So we're going to be setting up an outpatient service to provide for ER visits that may require just immediate follow-up the next day. Capture patients that come into the ER that need diagnostic tests by referring them to the radiology service and owning that patient when they come to the hospital. We're going to basically allow for opportunities to get IV therapy in the outpatient setting without basically patients staying in the hospital for the duration of a 14-day stay that may, again, translate to $14,000 worth of billing a day, versus you can just basically get them on an outpatient level of an antibiotic infusion. So yeah, this is not about increasing the amount of revenue going to GMH from Medicaid and MP. It's about really delivering efficient care given our reimbursement.
Can I ask, Tess, when you're saying then that you can do all this, change the law, reimburse 100%, but where's the money?
Yeah.
We did something very unique when we received ARA monies at one time. And we knew then that we weren't able to immediately go in and spend, all the monies except for projects that are ready. So in this case, if you can speak to CMS and ask them, and this is just an idea, of course, you might shoot it down, but where the 150 million, similar to the ARA monies that we got, is that we put it, yes, in a lockbox. Of course, there's no such thing as a lockbox in Guam, but at least hypothetically, we're saying it's a lockbox. So we put the 153 million in there. We turn around, though, with government local funds, and we use that, you see, up front to be able to use the 153, and then, similar to what we just did recently, is go back in there and continue to deposit that back, and that way then the monies would be readily available. Have you asked them that question? I'm sorry.
Unfortunately, Senator, they will only give you, you have to spend it first. You have to show the claim first, the total amount of expenditure that you have processed. You cannot do an advance. It has to be spent first. And you cannot draw down the federal money if you don't have the local match.
So then what we're appropriating, 16 million a year, I'm sorry?
It's MIP.
I mean, MIP, I'm sorry. What is the dollar amount that we've given for Medicaid?
Yeah, roughly 14
million.
for Medicaid. That does not include the ACA local match.
Yes, that I understand. That's true. And see, that's where I was saying that we need to get our neighbors involved, because one of the things we're saying is that if we could, and if they could, let's say, deposit into the Medicaid program $1 million, let's say, just hypothetically, could you use that then for the COFA citizens?
No, with regards to COFA citizens, we're charging them under Medicaid now. So even if you increase the reimbursement of MIP alone, those are Medicaid now. Inpatient services and ER services under MIP are all Medicaid now. They're being charged to Medicaid.
Through Medicaid instead of MIP?
Yes, instead of
that's
MIP.
You're
So
right.
even if you increase that reimbursement, when you charge it to Medicaid, we have to pay it based on Medicaid because you're charging it to Medicaid. So emergency room, hemodialysis, delivery, OB delivery, including ER services, are under Medicaid now. Because most of the clients under MIP are from FAS.
Now, on this side as well, is that in order to, again, the government to go to get a greater amount in the compact impact, because they're contesting, of course, our numbers because they're flawed in terms of how we're reporting this. Do you follow the Medicare data sheet? I think they call it like an edit field, to be able to collect all the data for everyone that comes in for Medicare. You follow that same format for Medicaid, so then we'll know who the first generations are and second generations, so that then we can take that information to the federal government, to Congress, and there's no way they're going to turn that away because they accept it for Medicare. And if we apply the same thing for Medicaid, then the same type of data collection, then that then would be information to give Congress then to increase their reimbursement for compact impact.
I have not seen that Medicare data, but with Medicaid, we report all the expenditures for Medicaid program, everything, by ethnicity. Even though they're U.S. citizen, we report them by ethnicity.
Yeah, but they consider that, to be flawed because, you're just relying on them. You don't have anything concrete. Anyway, I'll try to get the information for you, and I want to discuss that with you even further. So I'm giving you oral notice that I want to meet with Tess next week.
Thank you.
Thank you.
Thank you very much, Speaker Juan Pat.
Mr.
I want to
Chairman?
ask, yes.
Sorry, before you get too far, I want to go back to an earlier comment made by Dr. Shea that even if a patient has insurance, they're considered uninsured until they met the deductible. So if a patient goes into GMH and has $1,000 worth of services and they're on an 80/20 copayment, the health insurance company won't pay the $800 until the $200 is met?
Until the deductible.
Until the deductible. So,
Straight 80/20.
yeah, if it's an 80/20, normally most insurance companies are,
Let me explain this.
and 20% is the deductible.
Let me explain this.
No,
Senator.
that's
The
too
day-
different. It's different. The deductible,
No.
Senator,
Let me explain that, okay? Basically, when you have a $5,000 bill and your deductible is $2,000, they'll take the $2,000 from your $5,000 bill. So the hospital never gets paid the $2,000 bill. I've been wrestling with this idea whether the hospital should be penalized because the contract actually says that you have to pay. The patient has to pay before the deductible, the percentage kicks in. But unfortunately for us at GMH, we're at a disadvantage because the 2,000 is, basically taken off the total bill without the member even paying it. So those are the self-pay. They become self-pay and may not be uncollectible. But yes, in the hospital setting, it doesn't happen in the outpatient
But the
setting.
self-pay is for the total 5,000, not only for the 2,000. The health insurance company won't kick in any money until the $2,000
in the hospital,
is
they
met?
do. They'll take out the 2,000, and then the next will be 80/20.
Okay.
But the 2,000 is not. The contract for the government of Guam says you have to pay the 2,000 before the 80/20 kicks in. But unfortunately for us at the hospital, we get penalized for that. But I don't know what the answer to, because if they have to pay the $2,000 before the 80/20 kicks in, that's even going to be less money coming to GMH. So I don't have a solution for that, but except get rid of the deductible.
So what if we pay the $2,000 immediately for the patient that comes in, then that way immediately the 80/20 kicks in. That's much, the cost to the government is definitely much lower if we pay that 2,000 deductible. Then immediately the insurance company then should be able to pay the 80%.
The problem is that that's a lot of deductible you're paying because I think Guam program is only, you have to pick a deductible.
Yes.
Like for my private clinic, we don't have a deductible for my employees. They go straight on a 80/20 stay well plan, so there's no deductibles. If you want to do that, I encourage you to get rid of the deductibles in Guam plan. Rather than you paying the money, just negotiate a rate that says, hey, no deductibles, 80/20 straight. That's probably easier for you to get rather than you come up with the money and pay everybody deductibles.
True, but I still think we should work the numbers and see then that if we
Certainly.
if we pay the 20%, automatically the 80 kicks in, and then you're going to get the insurance to pay.
Yes.
Similar to what I was just saying is that it's much better for us to go after the 20% than to go after 100%.
So how is this applied in a private clinic when the patient has a deductible they have not met? When does
Self-pay.
Self-pay.
They have to pay.
Just
So when they- but when
to
they-
make it clear, Senator, because I know your question was if the bill is $5,000 and the patient has a $2,000 deductible, the hospital, and they don't meet the $2,000, the hospital still gets $3,000 from the insurance. That's correct, right?
60%.
They'll sign the 2,000
To the patient.
Okay, so the hospital still gets, so you're not out $5,000. You're out $2,000.
But in private sector,
Private is different.
yeah,
You have to pay. Yeah, I mean,
yeah.
the
So we
patient-
actually, this is the first time I'm hearing this, so I think that's good for Larry, actually. Yeah, now,
Yes.
20% is still the patient's
Yes.
portion.
right.
You got the deductible, then you got.
Want to go on the
the
mic? Because
No.
we talked about this in her audit, in her public hearing today.
didn't find out.
I mean,
So, that's the answer.
what we're talking about, Senator, is not going to immediately solve your problem. Going back to the bill, it's not going to immediately solve this problem. But going back to what Tess has said about GMH taking care of Medicaid, in the private sector, from the private sector side, we really don't mind that if you want to give all the Medicaid money to GMH and have GMH take care of all the Medicaid MIP patients, that's great. If you have enough doctors and providers to do that, I encourage you to do so. But I can tell you don't.
No, that was good to clarify that the health insurance company will pay the balance of what's ever owed to the hospital. Okay, yeah, thanks.
Great, thank you. So, Ms. Boleto, thank you for being here. I just want to also get a clarification for you because we know now that public health does not make payments. They process. So do you have a system there where you pay the private providers more than the hospital? I mean, how do you, when the claims come in, how do you make determinations on how claims are paid?
Well, our staff works very closely with public health, and so when they do the drawdown and we confirm that the funds are available, we cut the checks based on whatever that listing is that they provided us that match to the funds that come into the bank account. So there's no picking and choosing. It's based on what comes in. And I think if anything, We try to prioritize the hospital. We understand the situation they're in. Benita's very good at calling me and checking if that money has come through so she can get her check. And so, we just cut it as it becomes available.
Thank you. And I know that the DOA, the government, really bends over backwards. Because you have people who are so persistent, like Benita calling. So I know that that the government, the DOA, really does a lot for the hospital, and sometimes at the expense of our private providers.
Yeah, that's
Very true.
I can tell you that's true. Because I will call Tess, and she give me problems.
Yeah.
So I said, Tess, you know what? It's okay.
Yeah.
Give it to the hospital, but you can pay me late. It's charity care for our private clinics, actually.
Great. Okay, thank you. So we just want to get that clarification on record.
Based on whatever they process, and like I said, I know they work very closely with our staff, and we always inquire about GMH and make sure that as soon as those funds come in, that we turn around and cut a check to them.
Great. Thank you.
Yes.
Senator Morrison, do you have any? Senator Respicio? Senator Adat? Speaker? Anything else?
No, we get
Oh, we're in there. Yeah.
Well, but who's going to answer some of the questions that I have here? Now, it might not be for the rest of you here, but on the bill, I wanted to find out, and I don't know whether someone in the audience can answer the question, is the refinancing of A, B, and C, and I'd like to know what are the remaining terms of every one of these. Is there anyone?
We're just going to excuse Tess. So
okay,
thank
okay.
you very much. Thank you for being here this evening. We'll ask Mr. Carlson to please come up, but also just consider that we are having a public hearing on
Yes,
this, official public hearing
but I
on
want to
this.
get this
Sure,
information
absolutely.
beforehand.
And so, whatever questions we have, we can pose it now.
Do you have any other questions for me, or can I go too?
Yes, Doc, I know you're very busy, so if there's nothing else,
No.
Vice Speaker, thank you very much, Dr. Shea, for your service and for
Thanks
coming
your
here this
time. I know
evening.
you guys work hard.
Thank you.
Well, thanks for hearing us out. though. Thanks.
That's the least we can do. Thank you.
Yeah, so, Mr. Carlson, if you, do you know what the remaining terms are for these three outstanding bonds under Section 30, A, B, and C?
Give me 1 second, ma'am.
While you're doing that, maybe I can ask another question of Mr. Guillermo, is that, what if we do that line of credit, whatever that 30 million, 25 million, that's whatever that dollar amount is, and use that money to be able then to provide it as the funds needed as the matching for the 153? I'm just, because you're
sorry.
saying that we can't draw down from the 153 until such
Till we
time
spend-
then that we have
right.
the matching. And I'm just looking, what about the possibility of, if there is that line of credit?
If
I mean,
there's a line of credit, we can ask whether they would consider that.
okay, so can you just ask that
fund-
question
oh,
just
sure.
in case? I think it might be also
Sure.
good to kind of think outside the box here and
Yeah.
see what options are available to us.
And it probably would be related to what the conditions on that line of credit are also. But if it would just flat out say, look, you can draw down on that anytime you need it, and that would be like having cash. So we probably could get them to agree that we could immediately match that. But I also say to you, being in this business for a long time, if you make the $153 million immediately available by matching with a line of credit, it'll get spent before the end of 2019. And then the question you all have to answer, we all have to answer, is what happens if there's no more Affordable Care Act money? Okay, because prior to this, we had been living on a lot less. Okay, now we're eating filet mignon, okay, basically, and and we can see it. Okay, once providers and everybody else figured out that there's this extra money available, we went from spending $928,000 in 2011 to $31 million in 2015, and we're 9 months into fiscal year 2016, and we've already drawn 27 million. So it'll get spent. It's just a question that, and Tess and her people have done some great things with being able to maneuver cash and move it in and out of systems that, it takes a real pro to do that, and they've really done a great job with it. But this is really, I would give you that one caveat. Get that line of credit, probably get spent faster. And as I keep saying, we're not measuring any positive results. We're just getting people into a system, getting them units of care, but they're not getting any better in terms of their health status. I'm sorry, I think that's where we're failing everybody. We get them Band-Aids when they really need more than that, my opinion.
Okay, thank you. So, Mr. Carlson, do you have the
Yeah,
remaining terms for A, B, and C?
So the, just estimates, I'm sorry, I don't have the exact maturities for the three issues, but the Section 30 bonds are currently set to mature, I believe, in 2034, 2035 timeframe. The GMH loan with Bank of Guam is a 10-year loan that was, if I'm not mistaken, beneath taken out again in 2014. So
Yes.
that's that time frame. And then the Okkodo, that's the one I don't have right off the top of my head when that maturity is.
So I know that because I have the law here, when it was signed into law, it was 2010, and it allows for 30 years, but we weren't sure exactly then what the actual negotiated time
I
was.
believe it's less than that, ma'am.
Less than 30?
I'm pretty sure it is.
Okay, so the whole purpose of this is that you want to refinance it because you said that there'll be some savings.
Yes, ma'am.
At a lower interest rate. Do you know what that could be?
Yes, the latest run that we have, I actually have something to pass out if it might make things easier for you. If you
Mhm.
Okay, let's see about it.
There's two sheets here, and if I could ask for your indulgence so I could just walk you through the first sheet, and then that kind of opens, hopefully, the ability to talk about what the costs are associated with the amounts contained in Bill 340. So, on the far left, you see the existing debt service, and that amount takes into account what it is that we're currently paying for, as you mentioned, Madam Speaker, A, B, and C. And you take the total down. If we don't do anything, we're going to be paying $349 million with the loans that are currently in place, again, status quo. If you take the next row over, the estimated refunding debt service, and this again is on a matched maturity. We are not extending the maturity of any one of the existing forms of indebtedness. We are, for example, taking the Bank of Guam loan and structuring bonds that will run the remaining term up to around 2024. Similarly, we would take bonds and sell them to match the current maturity for the Section 30 bonds out to 2034-35 timeframe. So there would be no extension whatsoever. But that way you have an apples to apples comparison of what it is that's being contemplated here. And that amount would then be estimated to be $333 million. That's the total on the second column. And then the third column, and all of this is under the heading of Scenario 1. It details what the savings would be in total, and it would be $15.7 million.
What about for
This is, this is everything. This is
This already takes into account.
Yeah, so that if you-
That usually is about $4 to $5 million.
Yeah. If you take, like, say for 2017, the existing debt service, you see a number of $20,583,993. Right now, we're paying $15.8 million for the Section 30 bonds. We're paying around $3 million and something for the Bank of Guam loan, if I'm not mistaken, Benita. And then the difference would be what we're currently paying for the Okkodo expansion. So that $20.5 million is the total in right here in 2017 for what it is we're currently paying. So what we have done here, the Vice Speaker, the Speaker, and Senator Tom Atta were all present in a federal court hearing that was conducted, I believe, in March, where there was some discussion about trying to look at ways to be able to fund the post-closure costs for ORDOT, and we were looking at the opportunity to realize the savings from the refunding of the refinancing of Section 30 bonds again to address that issue. The court ultimately decided otherwise. So at that time, there was again some discussion led by the Vice Speaker to the effect that I'd like to be able to understand whether or not the reimbursement will be something that I can count upon when I'm putting the budget together so that I can make appropriations against it. So there's been some efforts on the part, continuing efforts on the part of the administration to work with the GSWA board to take a look at reinstating the costs similar to what the utilities do. You basically have a cost of service and a cost for the debt. So the way that the GPA and GWA's operations are and their costs are pegged is that first you have operational costs because you can't do anything unless you're a viable continuing operation. So you take that amount when you set your rates and charges, and the next thing is debt service. So then that would be, and then any other subordinate types of costs that would be considered in the case of the utilities by the legislature and of course the PUC. So then you basically come up with, for discussion purposes, $100. That takes care of operational costs, debt service costs, and other necessary costs. And then you set your rates and charges to be able to get that $100, and in some cases there's a little cushion that people like to see with respect to 1.25 times coverage. So what we are looking at here with the rest of this sheet here is, well, what if we started receiving those funds again? Because there was a point that was made to us recently, is that we're subsidizing solid waste right now, and that subsidization could rightly be, as the Vice Speaker pointed out, appropriated for other very critical needs within the community, such as the hospital, for example. So the point could be made that the hospital, through the non-reimbursement, is subsidizing solid waste, and I don't think that was anybody's intent ever when this bond was floated. So for the sake of showing what it would cost, and there would be some general fund relief associated with this as well, we take and we interject what the estimated GSWA payments would be, and then at the far right you see what the net effect is if all of that was to be effectuated. And the cost actually is significantly reduced, as you would imagine, because of having those funds finally available in full for the government to be able to utilize. So if I may take you to the next sheet, or do you have any other questions?
No, before you move on, Because you're saying that this refinancing is to save. What then would the savings be exactly, and at what percentage interest rates are we looking at?
The footnote on the sheet says estimated tax exempt non-AMT market conditions as of last week, Friday. So this is reflective of municipal rates as of last week, Friday. And the rates are in the neighborhood of, that's old. Yeah, it's well below 4%. Probably closer to, depending, as you guys all realize, that the shorter the time frame, so like for example here, we're only going out from 2017 to 2035, right? So that period of time in the yield curve is only halfway through. So for what would normally be a 30-year financing, when we go out and only go out 17 years or half, whatever that is, you don't really get to the far right end where you're paying, you know, the higher interest rates to investors, because the interest rates are exactly, they're shorter term. Most, it's yes.
So
correct.
this would be for shorter, but you got it 2017 to 2035. So you're keeping the same time period?
Yes, ma'am.
But that's for all of them, all
Yes,
three,
ma'am.
with the exception of Bank of Guam, it's only 10 years.
Right. So there's a way to be able to structure bonds that are sold to be able to take into account the time frame left for the Bank of Guam. So you structure those bonds, and similarly a little bit longer period of time for the Section 30 bonds, again never exceeding the existing maturity schedule that you have now, and then also for the Okkodo expansion.
So you're saying then that the municipal rates right now is about 4% or slightly below 4%.
Much less than 4.
Like
for this, particularly for this
so like 3%.
amount, this length. Blended, it's probably high 2, low 3.
High 2, low 3. Now, for the Okkodo High School, because that was the law that I had written, and I took advantage on the last year where the federal government, the Internal Revenue Code, basically would say that they would, in the financing of a construction, rehabilitation, or repair of school facilities, that they will pay a portion of the interest rates.
That's correct, ma'am.
And it was 7% when we got that loan.
That's correct.
And the federal government right now is paying 4.5%. So we now, the government's only paying 2.5.
That's correct.
So that's going to be a lot lower than what then you're considering, whether it's a high 2, a low 3. This is still much lower.
Right.
With the federal government paying 4.5% interest, and the
Correct.
government's only paying 2.5.
The estimated savings are primarily gained from the interest rate difference in the Section 30 bonds, because they're the higher amount. The Bank of Guam loan to the hospital, there's about $1.5 million in savings. The Okkodo is roughly around just north of about $500,000, because again, Madam Speaker, at the time it was done, you have a longer maturity time frame. So now that we're refinancing it and taking advantage of the 3 years or so that we've already paid, it's shorter term. The savings are north of $500,000, but more importantly, they have a lien on Section 30. And so if you pay off the bonds and you don't pay off the Okkodo, then you haven't perfected the lien for bondholders to have the first crack at the security of payment, which is Section 30.
You're right.
Yeah.
That's true.
So it's more really the fact of being able to perfect the lien, and there is nominal savings.
But we've done this before, is where then we can speak to Bank of Guam and have them as a subordinate
Yes,
to the
ma'am.
first bondholders. So
Yes.
therefore, I mean, we haven't even done that. We haven't even gone to ask that question.
The question is being asked, and the last time that this occurred, there was a price for the subordination. We paid $250,000 for them to subordinate. So in this case here, there should a subordination agreement be discussed and agreed to, it certainly could not and should not come with a fee attached to it.
Well, that's true. I agree, but I still think that we should try to ask again and maybe have them, you know, it's with their bank, so.
Yes, ma'am. And,
you know,
and
so I don't see why.
the discussions have already begun.
Well,
ma'am.
I would definitely have that conversation as well
Okay.
with them to make sure, because if anything else, you know, like the chairman said, that I would make a motion to delete the Okkodo High School.
And again, if the subordination is, again, everybody agrees and there's no fee attached to it, yes.
Okay, thank you.
Okay, so the next page, if I may.
We have a question. So,
Just on the initial issue of the 30 million, has the administration of both the hospital and Adelup discussed the possibility of a USDA loan? Was there some discussion earlier this year about a USDA loan at a low interest rate? I think it was 2 something. Were you involved in any of those discussions?
No, it's the family birthing center that is being funded by the USDA.
No, but a loan to do all the things at the hospital, to pay off the Bank of Guam loan.
No.
No. There's a perennial issue, sir, with how long it takes to work with the USDA.
You know, that's not true. It really isn't, because if the applications are properly filled out and USDA is willing to work very closely with the applicant, the process is like any other, you know, loaning institution. It's only when they need to go back. And also, if let's say it's going to involve a totally new place where there are archaeological studies that have to be done, then that will be a delay. But if you're renovating the hospital, you know, and like, for example, I think you're talking about going up for the parking, you're right, then all that then has cut back the time in the application.
Right.
I mean,
Personal
trust me, I mean, I've been
ma'am.
working real hard on this for the hospital,
Yes.
for the maternity ward, because I want this, you know, we started out with 3.25% at USDA. The day the bill was signed, the rates went down to 2.87, and then today the rate's at 2.7. And, you know, you can't beat that interest rate at all either. And they love projects like this, especially for the hospital. So why have we not considered USDA?
The legislature has always provided authorizations that allow for alternative financings as long as they're...
You're right. In
Yes.
all my bills,
Yes,
you're
ma'am.
right.
You're right.
You always use that as an alternative
Yes,
because I
ma'am.
know the interest rates are lower. But other bills that have been introduced do not use those alternatives.
Right. But the University of Guam project comes to mind. I was working on that at GITA. I went with Dr. Underwood and Dr. Leon Guerrero personally to visit officials at USDA in 2014 in December, and or actually earlier than that. And that process itself is my personal experience with the length of time it takes.
And I totally agree with you because we had to make several amendments to the law because we were talking about the liquid fuel tax, we were talking about the
TFF.
foundation as well. I mean, you know, there's so many other revenue sources we were looking at, and so many amendments had to be made before it was finally
Yes, ma'am.
I guess, started to move forward, but.
Yes, ma'am. You're correct.
Thank you very much, Madam Speaker. So we'll continue these discussions on the financing part when we have the public hearing
Sure.
next week,
Be
Monday.
my pleasure.
And so, but there's also one other thing that, as an alternative, is, and I brought it up with Gita in the past. I know you're not there, but it's the EB5 program. That's something that we don't utilize. We should. I mean, I don't know. I know talking to some of the I don't know what you call them. What do you call their offices here? But I've talked to some of them, and in the hospital project, like we were talking about using that program for the maternity ward, was something that could be attractive, for the program. But maybe for the Z wing that you guys are looking at, look at those alternatives also in terms of funding it. So, okay. Everyone, there's no other discussions here. We'll adjourn this informational hearing and have. Okay, she has. The Vice Speaker has a question.
Senator Tina wanted to ask, what's the timeline? Did we understand that something had to be done within a certain time period?
We would really, really like to be able to get an authorization as soon as we can after the public hearing next week. The vendor payables, the making good on that, on those obligations, being able to take advantage of current market conditions, and being able to assist you in the budget formulation, because if you look at some of the amounts that are contained on the second sheet, we've taken the debt service and taken the savings up front, and that provides assistance in being able to formulate the 2017 budget at a reduced cost.
But that'll be paid at the further down the line, is?
Pardon me?
Will that be paid further down the line?
The
When you take the savings up front, or are you cap buying it, or what?
With Bill 340, there's no need for Cap I because we're refinancing existing obligations and getting, $30 million, so there's no Cap I.
Okay.
You're just being able to take the savings up front to be able to get the monies that we need, but again, the budgetary relief is always paramount.
And Bill 340 is just
Yes, sir.
the 30 million or
That's
thereabouts.
correct, sir.
It's not the 160.
You're right.
And yes, Vice Speaker, I can confirm that. I'm the sponsor, so I can confirm that. Okay, great. Thank you very much for. Yes.
One more. I just want to make sure we say this, because it's usually we always try to do this, is give opportunity for any financial institutions here in Guam to be able to finance any of our projects. And the reason for that is because, the money stays here, and it definitely helps with our economy and, creating jobs. And so that 4.5% interest is paid by the federal government, and 2.5 here actually stays in Guam. So, we have to seriously look at that. The other thing that I wanted to ask is, how is it that, you did not consider at all, going to USDA for this particular loan? Is it the dollar amount that we're looking at here that you somehow?
I don't have the answer for that. If you were to ask me my personal opinion, which I gave a little while ago, it's a timing issue. I don't know whether or not, I'm certain USDA will do new facilities. I'm certain that USD will do a myriad of other construction type related programs, but I don't know if they do refinancings. I don't know whether or not it's something that they would entertain. I don't know if it's I just don't believe
I'm getting the sense here then, you're right, USDA will be for construction,
Yes, ma'am.
rehabilitation, but refinancing, so really the crux of this bill is really the refinancing. It's not so much the infrastructure, the capital improvement, but the capital improvement is to make this look good so they can get the refinancing. That's what I'm thinking of.
You know, if sequentially there was a thought provided and it was confirmed to everybody's satisfaction that USDA would in fact be able to entertain the CIP portions, and there was a consensus that a timeliness would be, addressed. Madam Speaker, you just reminded me of another reason why I have an issue with the USDA. Their staffing shortages provided a problem that they put on the shoulders of the Government of Guam. They don't have the ability to do incremental finance drawdowns, as you know, like when you do footings and foundations, and that DPW comes over and signs off, then there's a payment that's due to the contractor. They wanted us to get an intermediary lender to do all that stuff, and then when it's all said and done, they would do the takeout financing. So that became one of the problems that GIDA had to address with respect to the University of Guam project, because they won't be involved in incremental disbursements. They will, in fact, after everything's done, blessed and ready, just like when you get a mortgage loan. Exactly. You pay a little bit higher interest rate at the bank while your house is being built, but once it's built and it meets all the Freddie Mac requirements, then the bank sells the note to Freddie Mac, and that's where you start getting the low interest rate. But during construction, you're paying a higher interest rate. So the ability for USDA to do that loan for the university also had some challenges from their staffing perspective, and that required the government to satisfy their need to find an intermediary lender, and one that didn't have an exorbitant cost associated with being able to provide the money up front and then you would be taken out later on by USDA.
Would FHA have been available to do that?
Beg your pardon?
No, not FHA? Okay.
I don't think so, sir.
The last thing is for Ms. Linda there, is that it seems to, the consensus has been is that, at least from what I heard this evening, is the need to hire then this certified, what do you call that person?
Coder?
Certified biller. Are you guys going to do that? I mean, you said you're training, but there's a difference between training and getting somebody who's really fully certified?
Yes, it's hard to find those type of people here, Senator. You know, we have, in the past, I understand that there were some that go on and get their certification, and then as soon as they get their certification, they leave because we don't pay enough. And but for our part at GMH, you know, we have been training. We're providing training for the coders because you know there's two different things. There's the coders, there's the billers. And so we are providing training for that, and you know we're also working with GCC for the billers. It is very difficult for hospital billers because the courses that and training that are available on island are geared to clinics, outpatient services, and primarily the hospital's billings is inpatient. So, but we are working with GCC, and originally they were going to have the training in July, and then they for some reason, you know, they had to reschedule, and it's happening in August.
Before you came on, did I understand that the previous administration of the hospital had a contract with a off-island firm to do the billing?
Yes, and that was a disaster.
Okay.
The staff at GMH had to redo those billings, and you know, so it didn't work. So when you bring other people in, I mean, you know, that doesn't necessarily mean that it's going to be good for GMH. We've done it and it didn't work.
How about contracting to bring somebody on island to actually do it here? if I'm not mistaken, how many additional people have you added to your staff since the beginning of this year?
We have, I mean, you know, we have maintained the same number of staffing that we've had. I don't think that we've added additional.
You've hired a new deputy CFO, correct?
Well, we were referring about billing, so I didn't.
No, I
you know,
mean, but
yes.
no, just your office.
Yes, I mean that's for all the fiscal areas that we're looking at. There's a lot of things that needs to be done, and that's what we're lacking is the upper level technical help, professional help.
And if you ran an ad in the professional journals in the States for a professional certified biller, would his or her annual salary be more or less than the cost of the two new recent hires in your office for a assistant CFO and a...
Senator, with all due respect, you keep harping about certified billers, certified coders. We built $15 million more last year than the year before.
And whether or not those bills
we
are
have,
correct.
I think the coders, they're doing a great job. Their error rate is only 1%. And so, that their work speaks for itself.
The collection will speak better for it.
Well, we collected $5 million more last year, fiscal year 15, than the year before, and we project to collect an additional probably more than $4 million again this year, more than last year. So we are beefing up. We're looking at every area, and we are monitoring the collections, the billing. We meet with the staff on a weekly basis or sometimes on a daily basis to go over issues that we can resolve as a group. So we're working with all the different departments. We're working with the doctors to ensure that they do their part, the nurses, and we're always looking for other charges that we can capture. So I think we have made a tremendous improvement at GMH.
And just analogizing it to an addict. If they're not willing to admit they have an addiction and a problem, they're never going to be able to address it. And you guys are unwilling to accept the fact that having a certified biller would assist you. You just don't want to address it.
No, I mean, that's not necessarily true. I mean, it's good to have those certified billers, but we've brought those HRG when we contracted, and they're certified billers, but our staff ended up having to clean all the billings because they didn't understand the billings at GMH, and a lot of those billings had to be redone. So certified doesn't necessarily mean that they're better than the people that have been doing it, and we have brought in some other coders also that, and then we have ordered materials, and we provided training materials for them, and we have an excellent manager at medical records that's really guiding this group, and we have a hardworking business office staffing that are really going over on a daily basis and ensuring, making sure that the claims are accurate.
Madam Speaker, the Okkodo maturity is 2029. Yes, ma'am. No, that's the Section 30. So Section 30 is out to 2034, 35. Okkodo's 2029, and Bank of Guam is 2023, 24. Yeah.
Great. Okay, I want to thank you all again. It's running really late now, so we'll come back for the public hearing next Monday when we deal with Bill 340. Okay, we're
Mr.
adjourned.
Chairman, I
Thank
also
you.
had some information to share in the informational hearing as well.
Okay, you have an opportunity. You're a member of this body. If you're not up here, you just lost your chance. And I'm not going to allow any grandstanding on my time. So we're adjourned.
I
Thank
don't
you.
intend to grandstand, but I do have some information to share of the informational hearing for everybody, the public, to consider. As a matter of fact, he even made a statement today inviting everybody to offer any information they had to share.